Good morning, Chairman, and distinguished colleagues. It's my honor to be here today to present a work from our team uh, titled with the Genotype phenotype characteristic of Vietnamese patient diagnosed with the Charcot-Marie-Tooth disease. As you know, that the most frequent form of the inherited neuromuscular disease is the Charcot-Marie-Tooth disease, the CMT, that with a prevalence of 1 to 5,000. And the disease onset can start at any advanced age, but typically in the first or second decade of life. And it can affect both the sensory and the motor nerve. With the clinical manifestations were the muscular atrophy and weakness and sensory loss. In the early onset form, we can see that the motor milestone can be delayed along with the muscular atrophy, and the foot deformities can be observed in these patients. Now, the diagnosis of the disease is basically depending on the clinical characteristics and electrodiagnostics. It's very important to have us to diagnose the disease and also to classify into the two main types of the CMT disease, the demyelinating CMT form or the CMT1 and the axonal form CMT2. Currently, the treatment, there's no effective treatment for the CMT disease. And we can see that the patients who got the CMT disease have complained that living with CMT is living in fear of the future. It's hard watching your body decline, knowing that nothing can fix it. Nowadays, the patient treatment based on the rehabilitation and occupational therapy, the pain therapy, and with the regular following up depending on the disease diversities. So it's needed to have an effective to have our patients. Nowadays, the molecular diagnostics have helped us to allow us to understand more about the mechanisms of the disease, what problem with the myelinations or what the problem with our axons. So more over 100 genes have been confirmed to related to the molecular mechanisms of the disease, and is the way for us to think that to find a gene therapy to editing or to fix the problem in our genes to help the patient. You can see that more over 100 genes have been defined to be related in different types of the CMT, the demyelinated CMT, the axonal CMT, or in other inherited motor neuropathies. But there are 4 genes that can be comprised of more over 90% of the disease. These are the PMP22 duplication, the MFN2 genes, the MPZ genes, and the GGB1. It can be autosomal dominant form inheritance or the autosomal recessive inheritance pattern, or also the X-linked form of the CMTs. So when we divide in clinically and based on the electrodiagnosis into the demyelinating form, the axonal form, intermediate, including with the family history, is very useful for us to distinguish the subtypes, or will direct us to which genes can be done to examine. So why we emphasize the role of molecular testing? We can see that when we know which genes is affected, it's very useful for us to understand more about the disease mechanisms, and it will lead to help us to identify our target or promising in genes approach. Now there are many trials to find out the effective therapy for our patients, and it may include the non-virally or virally mediated with different genes. We can try to silencing, addition, replacement, or also editing the profiles. So we have learned a lot about the work with many publications about the gene, the trial with the gene therapy. Our question is that where we are in research of CMT disease in Vietnam. In 2016, accidentally in a university medical center EMG unit, we met a 16-year-old girl who has a problem with the motor difficulty. Actually, she, with her family, has gone to many different hospitals and met a lot of doctors. And when we take the history of the patient, we know that she got her difficulty in running at the age of 27 months. And she can independently climbing to the stair to the age of 7 years old. And she need an ankle foot orthosis at each age. The progressively distal muscular atrophy, so at the age of 8 years old, she need crutches. At the time when she came to the clinic to have a clinical examination, you can see that she got an atrophy of the legs, arms, and absence of deep tendon reflex. And when we do the nerve conduction study, we cannot measure any activity of the investigated nerve. When we ask the patients and her family, we know that she has the two siblings with the identical symptoms progress. And so why their parents are normal with no problem with motor or sensory problems. And we think that this could be an inherited neuropathy that affects both the motor and sensory nerve. And we decided to do a molecular testing on this patient. At that time, in 2016, we don't have any tool to evaluate the genes nowadays. Nowadays, you can see that many places, many clinics can have the next generation sequencing to analyze the whole genome, the whole exomes. But at that time, there's no place to do the molecular testing in Vietnam. It's also there's no place to test the CMT genes. So we have to make clear about the clinical of the patients and to try to figure out which subtype may the patients can be in, because you know that the CMT can be divided into CMT1 and CMT2, but it can be divided in more subtypes, and which is subtype it will have each kind of the gene mutation. And we have a Sanger sequencing. At that time, we focus on the mutation in the GDAP1 genes, and then we broaden the gene panel. Luckily, we found that the homogeneous mutation in the GDAP gene, that there's an insertion from the nucleotide 661 to 671, and it causes premature stop codon in the protein and lead to a truncated protein. So it means that now the mutant protein is shorter than normal, and it can lead into the abnormal of the axon, the cytoskeleton of the neurons. And her two siblings has also the same mutant, while their parents are heterozygous mutant. So now, because you can see that Vietnam has more than 90 million inhabitants, it has a very large population. So we wonder that the prevalence of the CMT in Vietnam and the clinical, the molecular characteristic of the CMT patients, because we still have that when the more we know about the clinical, about the molecular problem of the patients, and the more we can find a way to get to the gene therapy in the future for the patient is other neurological disease. We made a panel of 11 genes that has been studied widely in other many studies. And we find that we recruited 31 patients of CMT into our research, and they have the motor difficulty in the first or second 2 decades of life with a typically phenotype of the CMT disease. By using the electromyography examination, we have classified the patient into the group of CMT, demyelinated CMT around 52%, the axonal CMT about 40%, and the intermediate form around 10% of the patients. And then we do the analysis of the targeting of 11 genes, and we can define the causative genes is for the CMT1 and CMT2, and we determine the 4 genes affected in our cohort is the PMP22 is the most frequent mutant in our cohort, the MFN2, the NEF4, and the GGB1 in our study. I would like to present more detail into the 2 mutants found in our study. The first one is the PMP22 mutant. The reason why I want to introduce about this case because that based on the clinical examination and the electrodiagnostic, we thought that is the CMT2, the axonal CMT form. But when we do a molecular diagnostic, it's confirmed that this is the problem with the PMP22 protein. This is protein that will comprise of the myelin of the nerve. So by using the genetics testing, it confirmed the diagnosis of the CMT1 instead of the axonal CMT, like as the clinical diagnosis. The second case that about the mutant in the NEF4 genes. The position of the mutant is at the nucleotide 64, and it leading to a change in the amino acid 22. When we compare among species, we can see that it seems that it is conserved among species, and it's proposed that it can be a mutational hotspot of the protein. We also try to analyze the genetic feature of the patient's family, and we get 5 family of CMTs, and you can see that the features of the MFN2 mutation is the autosomal dominant inheritance, with the while the GGB1 is an X-linked form CMT, and the 2 other is the recessive form inheritance patients. Actually, nowadays, with the development of many methods, especially the next generation sequencing that allow us to learn more, to know more about which genes is affected. But actually, not all the patients have the opportunity to approach the gene testing. So we propose an approach for the genetics to when we have a CMT patient, which step can be done for our patient, which will be less time consuming, is also with the cost available for our patients. So it's very important to base on the clinical symptom and nerve conduction studies, because the doctor cannot write a prescription that this is a CMT disease and send to the into the genetic clinic and ask them to do the whole genome exome. Is very expensive, and maybe it's not good for the patient. Yeah. So we through this study, we have a genetic approach for the patient. So you can see that it's very important. Once again, I want to emphasize that Professor Umbati also said that it is very important to base on a clinical examination. Yeah. So from what we have done from our study, we think that the first thing when we have a patient with peripheral neuropathy, it's very important to have carefully taking his the patient information, the history, family, as also the carefully clinical examinations. And then we will do next the role of the electrodiagnostics to help us to define the demyelinating or the axonal form or intermediate form of the CMT. So what about the role of the molecular testing? Because you can hear that I emphasize the role of clinical examination. So is it needed to do a molecular testing? Yes, it is needed. Why? Because you can see that from the first patient we have in 2016, the patient have gone from hospital to hospital, from a doctor to another doctor, because they don't believe that they get an inherited neuropathies. They will think that there's some problem and it can be fixed. So they don't believe in the current doctor, so they have to go through and through so many hospitals. So with the molecular testing, it's a tool, a very useful tool for us to determine that these are inherited neuropathies, and is the way that to help the patients that is not useful to go from hospital to another hospital. So it focuses on the rehabilitations therapy for the patient and with a regular following up the patient. When we know about the genetic profiles of the patients, the more we understanding about the molecular mechanism, the pathway, the cellular effect of the mutations is a way for us to think about the gene therapy for the future. And nowadays, when we see many advantages of the gene therapy in many other disease, is also the SMA. You can see that it's very effective to use the gene therapy. So we hope that in the near future, there's also a therapy for our CMT patients. At the end, I would like to thank you a lot to our team. It's needed the collaboration between the neurologists, the geneticists, with the combinations with the basic medical science to the clinical medicines, and from bench to bedside. And we hope that in the near future, many clinicians will know the role of the molecular testing and use it as a powerful tool to help the clinicians as other many clinical skills. Thank you a lot for your attention.